my MBBS from Gujarat Cancer Society in Ahmedabad itself, and then
Okay.
postgrad from Sola Civil Hospital in Ahmedabad itself. And now I have joined Swarsudha Microsurgery Clinic with my dad since 2 years.
Okay. So what do you focus on? What is the case focus? I mean, is it mainly skull base or is it mainly cochlear implants or what is it?
It's mainly ENT practice, but more so on rhinology, because I have done the most surgeries I've done is nose surgeries. Special interest in vertigo, of course, because there are just way too many vertigo patients that I've seen in just 2 years. I've seen about 200 vertigo patients.
Dr. Vinod, you're a doyen of neurotology in India. You were the president of the NES. You, in that sense, you don't need introduction. But I think what is unique about you is that you are an innovative surgeon, an innovative inventor, and I think we really look forward to the collaborative work we are going to do together, and we really look forward to the pearls of wisdom which you're going to share with us. So the floor is yours, Betty. Please
Thank you so much. It's an incredible honor to be here. I'll just share my screen. Okay. Can you see my screen now?
Yes, we can see it. Go ahead.
Okay. So this is a very special case about multi-canal BPPV, and it's also more special because we could actually diagnose it and treat it with the help of the chair that you see in all these pictures around the main frame. So I am Dr. Paridhi Khandar. I work at Swarsudha Microsurgery Clinic, and which has been a center of excellence for vertigo since 1988, and which is run by my dad since then. So right now I'm just under his tutelage, and I'm going to go ahead with the case report now. Okay. So this is a case about 66-year-old male diabetic patient who also had cervical spondylosis, who had presented to the OPD with the complaint of episodes of brief but intense spinning sensation of the surroundings since the last few months, with a feeling of rotation when he turned on the bed. And similar sensation was also felt on bending forwards or looking up. He had difficulty in walking in a straight line, and he had been to various clinics and had been treated by various neurologists and ENT surgeons, but with no to little benefit, almost no benefit. And when he came to us, he was prescribed and he was using 3 different labyrinthine sedative drugs. And in the past history, he had similar episode 2 years ago, but the sensation of spinning was milder and on bending down and going from sitting to supine position. So in other history, he gave us the history. So the patient had come to us after going to a lot of different clinics. So we had all the case reports. So Epley's maneuver had been performed elsewhere, but it reported that it had not been done adequately because of the patient's non-compliance and due to cervical spine issues. So there was no positive outcome of that maneuver. And the intermittent episodes gradually became more frequent and more severe, especially on rolling over in bed, as a result of which the patient became very phobic of falling asleep, and he had a different body language of stiffening, and there was a lot of visual compensation that was going on. So, and now he was feeling extremely handicapped because he needed help in even walking. He had no other history of ENT troubles, no tinnitus, no deafness, but the patient was using cervical collar because somewhere he had been told at some other clinic that due to cervical spondylosis, that could be one of the reason for the vertigo, but there was no significant benefit despite using the collar for almost 2 months. And he had no other comorbidities. And on examination, all the vitals were normal. ENT examination had normal findings. CNS examination was also not significant. It was difficult to perform on an OPD basis the video head impulse test, and the patient had already come with certain blood tests and MRI with contrast, all of which showed absolutely no positive findings. So we suggested to, first of all, stop all anti-vertigo medications and sedatives for 3 days, after which he would return to us for vertigo and audio evaluation. And furthermore, we asked him to undergo the VNG again. He had undergone the VNG at a different place, as mentioned, but this time it would be on the mechanical BPPV chair, and thereafter the corrective maneuver would be done if required. So this is just a slide showing the BPPV chair and how it can help with the perfect, precise positioning, and angulation can also be maintained. Even in patients with cervical spondylosis or other things, the head is fixed. Even with patients with phobia, the patient is harnessed. So despite the presence of vertigo, the patient cannot move or change the position, which would be ideal for a patient which is such a case, which we are seeing right now. So on the primary investigations for the central, there was no spontaneous nystagmus seen. There was no Saccard smooth pursuit case evoked nystagmus, optokinetic nystagmus, everything was normal. But the video head impulse test we performed on the chair, and it was positive bilaterally. So now going ahead for the positional tests, these showed very interesting observation. So, and this was, we expected it to be our final diagnosis. So we start performing from the suspected canal in the sequence of posterior canal. So for that, we do the Dix-Hallpike test. Then we'd go for the lateral canal, the McClure-Pagnini test, and then the anterior canal, which is the deep head hanging supine test. So the left Dix-Hallpike and the McClure-Pagnini test both showed nystagmus. The left Dix-Hallpike showed direction changing nystagmus. And however, this direction changing nystagmus reversed in direction on returning to the original position. So here I have a little video showing the left Dix-Hallpike test. Here in the video on the right side, we can see the head position as is fixed on the chair with a gyroscope. And the eye we are seeing closer to the head is the left eye of the patient. So this is the left side and this is the right side. And we can see that there is some gaze instability that the patient already has initially. Here the patient's head is kept in extension as is required in Dix-Hallpike, and the chair itself is rotated 45 degrees to the left. Now the patient has been put in the supine position on the left side for Dix-Hallpike, where we can see left beating horizontal nystagmus. This left beating horizontal nystagmus lasted for a little while, and then it started to change direction. So this direction initially that we are seeing was left down beating. But then it became vertical for a few seconds, and then it started becoming right down beating. And this right down beating nystagmus, as was observed on the various graph findings, had the greatest slow phase velocity of all the three nystagmus. Okay, now the patient is brought back to the sitting position. And here we saw that the nystagmus direction had reversed. Now we're seeing the nystagmus is beating to the right in the horizontal part. And a little bit of the torsional component is also seen because the nystagmus, there is a tug of war between two different types of nystagmus. Okay, so that was the left Dix-Hallpike test. I'll come to the analysis of this in a bit. Next we did, since we saw the horizontal nystagmus, we did the McClure-Pagnini test next. And here is the result. First, we're turning the patient's head to the right side. The patient's head in this case is in flexion. and patient is lying on in supine position. Now the patient's head has been turned to right lateral position and the flexion is maintained. Here we see geotropic nystagmus as the nystagmus is beating towards the right side. This diminished when the patient was brought back into the supine position. And now the patient is turned to the other side, which is the left side. In the left side as well, we saw geotropic nystagmus, but this one was much greater in intensity and velocity as compared to the right side. So left geotropic nystagmus and right geotropic nystagmus, both were present, but left was of greater intensity. Even the slow phase velocity was greater. And then it has a classical crescendo-decrescendo form of nystagmus. So considering the very brief durations of each episode and the fact that the nystagmus had a crescendo and decrescendo fatigable nystagmus quality, and along with all the central nervous system testing being normal, the positive head impulse test and normal MRI, along with the dizziness handicap index, which was taken prior to all of these testing, we could rule out a central cause. So we considered it as a multi-canal BPPV and diagnosed it as right anterior canal BPPV with left horizontal canal BPPV. Now I realize right anterior canal is quite rare. I mean, anterior canal in itself is a rare finding, and left horizontal canal BPPV could have actually affected the torsional component. But multicanal BPPV in itself is a rare finding in patients which do not have any prior history of head injury. So this was a very essential point in this case. Now, so we went for the corrective maneuvers. We went for the cement maneuver for the right anterior canal first, since we calculated the slow phase velocity of the left lateral and right anterior canal nystagmus, and the slow phase velocity for right anterior was greater. After which the patient was indoor and he had been given rest for 6 hours, followed by which we did the 360-degree barbecue roll for the left horizontal canalithesis correction. So after that, we evaluated the result and gave a post-maneuver plan, and which was basically treating the patient for the BPPV, for residual BPPV if there was any, and then counseling the patient about the possibility of persistent postural perceptive dizziness. So there was this kind of counseling at discharge. First was the patient education. Patient education in the form of the nature of the disease, the possibility of recurrence, the possibility of it affecting the anxiety levels of the patient and thereby inability to compensate. Then there were certain vestibular adaptation exercises given. These exercises are the standard exercises that were given since the patient had become a lot less ambulatory due to phobia. The adaptation exercises and the counseling also included telling the patient that more movement will aid the recovery and adaptation of the vestibule in a quicker way. Third of all, pharmacological requirement. Now, at this point, the patient had already spent a lot of time, effort, money, mind space into this treatment. And then if we tell him you still have to take lifelong labyrinthine sedatives, that's not fair. So we had to counsel the patient about the pharmacological requirement in his case and how we were going to taper off the drugs. So we prescribed this patient with an anxiolytic because he was also diagnosed as having a neurotic type of personality prior, and he was very anxious about the entire disease outcome, as is natural when you go to so many patients and so many clinics and it has not been resolved. So that anti-anxiety medication counseling was done to him, and then he was also counseled about there could be a possibility of recurrence of minor episodes, but follow up for repeat maneuvers will be done. And we counseled him for various things that are allowed and various things to avoid. So the patient outcome on follow-up was with improved gaze stability. As we saw the little bit of gaze instability at the beginning, that was completely gone. Fall risk was completely reduced as compared to the initial dizziness handicap index. The next time the patient came, he actually came walking on his own. He did not even have a walking stick, much less someone else who was holding his hand. And so there was improved functional gait ability as well, and improved balance confidence. So the maladaptive responses such as stiffening of the body language and posture or visual dependence too much, all of them were gone, and we immediately weaned off all medications as was required for this patient related to vertigo. So this, I want to especially mention this in conclusion of this case, that all of this was possible for this particular patient, and there are so many other patients. This was just because of the BPPV chair, where we were able to hold the patient in the appropriate position for the duration of the time, despite the patient being very anxious and fidgety and very gingerly about going in certain positions. The position was maintained for the desired amount of duration, 2 minutes or 3 minutes as is desired. And the speed and acceleration was also taken care of, and the extension and the flexion despite the cervical spondylitis without damaging the cervical spine. And the perfect angulation of the chair was also maintained because of the mechanical nature of the chair. So why did we choose this case? So there are multiple reasons. First is that multi-canal BPPV, as I said, is considered rare. Second is that there was a lot of confounding findings that mimic central vertigo. Like we saw vertical nystagmus, we saw nystagmus that was direction changing. There was there were a lot of signs such as the patient could not walk in a straight line when he came. So there were a lot of signs why the patient had been referred to a neurologist. But all of this needs to be kept in mind, that people are reluctant to make this diagnosis since it is so rare. When there is, especially when there is no history of head injury, people are quite reluctant to make the diagnosis of multi-canal BPPV. But it is important to bring this to note that this could really help out certain patients where sometimes they are diagnosed as central positional vertigo, which is actually a diagnosis of exclusion. In this diagnosis needs to be excluded because before you go for that diagnosis. Then the importance of the patient counseling in cases of chronic vertigo. Now, chronic vertigo in this patient was one of the major factors, but also multi-canal was a major factor why the patient was so anxious. But in some patients, also in this patient, they have neurotic type of personality, history of that kind of personality, or anxiety disorders, or patients have just different reactions to diseases or disease etiologies. So patient counseling and cognitive behavioral therapy is an essential part of a lot of chronic vertigo cases, and demonstrating the irreplaceable nature of the mechanical chair as a treatment modality. So this was why the case was chosen. Okay, so that's it for my presentation.
Number one, let me congratulate my beautiful presentation. Okay, I heard the key areas of all that, and I was really impressed. So first, thumbs up, a good thumbs up to you both, I think. So could you just take the discussion on one or two streams? The first stream, and this you could do between the two of you all in case I'm erratic in my reception. Take the discussion on how often do you see multi-canal BPPVs, number one. And number two, what is the sequence of testing and maneuvers in BPPV? If these two things can be clarified, I'll be with you all as long as I can. But if I fade out again, just continue the discussion on these two streams and then take questions. And we know you can be the master of ceremonies.
Yeah, sure. Paridi, I think you can answer both of the questions.
Okay. All right. So this, if you can see the screen, in case of single canal, selection of the maneuver of the canal is fairly simple. But in case of multi-canal, first of all, we have to figure out which is the poorer side or the less functioning side or the greater vertigo causing side. So in our case, for instance, we calculated the slow phase velocity for that. So first we see the slow phase velocity. We see the number of nystagmus beats to decide the worst side, and then we treat that first. But if there is an involvement, equal involvement of all the sides, then we go for the posterior canal first, then we go for the lateral canal, and then we go for the anterior canal. And in our experience, all of them can be treated in a single seating, but in a lot of literature, it has said that you should give a gap of about 6 hours to a day or about 48 hours. So that depends on the patients and patient sensitivities. So in this particular patient, the patient was really scared that he could not move in the first episode of vertigo that he got. So that is why we had to give a break of 6 hours. But after one canal was treated, he was feeling significantly better. And right then he was ready to go for the second maneuver right away. So it actually depends on the patient sensitivity. And
so I note that Dr. Watts has entered the chamber. Dr. Watts, can you unmute your speaker and just give us your input on do you have any sequence of doing maneuvers in multi-canal?
See, there are two schools of thoughts. Can you hear me?
Yes, we can hear you loud and clear.
There are two schools of thoughts. One is that because the posterior canal, because of its peculiar anatomy, it is considered to be the reservoir of otoconal debris. So treat it first. Then, if you have got a horizontal canal as well, which is the most common combination, the ipsilateral posterior and horizontal canal. So then you treat the horizontal canal. So some people may question this approach because they say that the horizontal canal produces more severe symptoms, especially the neurovegetative symptoms. So treat that first. So, but the correct strategy is to treat the one with which is considered to be the reservoir, because the otoconia won't come out of the posterior canal unless and until you do apply or Simot maneuver. And then you can ask the patient for a forced prolonged positioning on the opposite side and call the patient coming morning, and the two canals may be treated over a period of less than 24 hours. That is my take. Although recently I treated one patient of tricanalolithiasis, bilateral posterior canal, and the apogeotropic right posterior canal. That is, there were two otoconal clots in right side, one in the periampullary location and one in the ampullary location, which I showed in the Venta meeting. So I did.
So I think Dr. Vinod, what would you say to this? What is your take on that?
I'll compare and select the sequence based on a slow phase velocity. Second parameter, number of nystagmus bits, is more important. The canal where slow phase velocity is highest should be treated first, and lower should be second. That is how one should select. But and always we in our center always we do like that, and because of availability of a VNG and it's all parameter, now it is very easy to have these data.
Okay. So I see a hand raised by Dr. Sandeep Kumar. Would Dr. Sandeep Kumar unmute and ask his question?
Sir, first of all, I have objections to it being a multi-canal BPPV. 5788. Yeah, 5788. Hello. Yes, sir. Sir, how can you explain a bilateral hit positive with multi-canal BPPV? Number one. Number two, the inversion of nystagmus from left down to right upbeat nystagmus on left disc pike, it should not be that strong. Reason being, it would be due to ampulofugal flow. So and why should it in the transition become only downbeat or vertical? Third, why should a patient of BPPV have imbalance? Fourth, what was the duration of the patient? Why while he was already treated with multi-canal VPP, by the apply and other things. So these are four major objections to it being a multi-canal VPP. Then we can talk of other things like which maneuver to do first and other things. Thank you, sir.
Okay, no, I think that is noted.
I think
Thank you.
Paridhi, you can answer, and then if required, I'll answer that.
The nystagmus that was seen on Dix Hall Pike was left horizontal to begin with. So there is this cardinal rule where you see the direction of the nystagmus instead of the maneuver that you're performing. So with that left horizontal component, we figured out that the horizontal canal involvement is going on. Then after the horizontal canal particles settled in the most dependent position, the nystagmus beat changed to right downbeating for a little while, and then it changed to left downbeating. Now the left downbeating was significant of left anterior canal BPPV, and the intermittent right downbeating nystagmus that you saw was actually a product of the vectors that are formed in the two different directions of the nystagmus. So first vector is in the left lateral horizontal direction, and the second one is in the left anterior direction. So the vector that is formed is right downwards beating. So this right downward beating nystagmus, which was transient, was just because of the vector. The left downbeating nystagmus was because of the left anterior canal involvement. And once the patient was brought back, the reversal of the symptoms were for both canals simultaneously. So we could see a little bit of torsional element, but the horizontal canal nystagmus was reversed completely. So right beating nystagmus was for the major component that was observed. And since this was for the horizontal canal, as we can see that in horizontal canal, even on McClure-Pagnini, despite it being just one-sided, we'll see geotropic nystagmus on both the sides. So on bringing back, we would see that geotropic nystagmus on right lateral position. On bringing back, the left lateral would have converted to the right lateral, the reversal as is seen. So that is why it was of a little bit of longer duration. Plus, in patients of a longer duration of chronic vertigo, there is greater number of autoconia or that have accumulated along the nidus of the original autoconia. This is something that happens in patients of chronic vertigo, which is why the duration is much longer. It is a very common myth to say that the duration when even in reversal, when it is longer, it is supposed to be a CNS nystagmus is the central cause. But that is actually not true due to multi-canal BPPV or even for cupulolithiasis.
So there was a question from Zubair. There was a question from Zubair Mohammed. Zubair, would you like to ask your question? I think it was regarding lateral canal or.
Hello, can I speak? Hello.
Yeah,
I am
Zubair.
It is regarding why is the diagnosis of right anterior canal was made. How was it? Now I think she explained. Dr. Paridhi explained as a left anterior canal. Was it a right anterior canal or left anterior canal?
Right anterior canal and left horizontal canal. I'm just
right anterior. Can you please explain how you make the diagnosis of right anterior canal?
So as I said, the nystagmus direction is more indicative of the canal instead of the maneuver. So while we conventionally do the Dix-Hallpike maneuver for posterior canal, the direction of the nystagmus, if it is the involvement of the same side posterior canal, should be upbeating in the same side. So if on left Dix-Hallpike, the direction of the nystagmus was left upbeating, then it would have been a left posterior canal. But since the direction of the nystagmus was right downbeating, it was more indicative of right anterior canal BPPV.
Dr. Zubair, are you satisfied with the answer from Paridhi, or?
Okay, thank you.
Thank you. Any more questions? Then it will be great.
Can I ask one more question?
Yeah, go ahead.
Yeah,
Go
sure.
See, the patient came after, once the patient came for second review. Will you do any of these tests repeatedly to see that whether this has subsided or not? Will the patient undergo again this positional test to see there is no nystagmus?
So this patient was confirmed. In fact, when he came for follow-up, he was practically symptom-free, almost symptom-free. Of course,
Okay.
he was sent for certain rehabilitation program also, but
Okay.
practically he was cured.
Okay, thank you.
So go ahead, Parinidhi. Tell us about about your chair. You had some slides. You can go ahead and share that.
These are just some slides that showcase the chair, but the head can be harnessed. Everything is harnessed, and for different, and we can observe the eye on the screen. So this is a setup that has been created for in a very ergonomic way. Rotation on every axis is possible in this chair, so all the three planes are covered, and this chair was particularly very helpful for patients with cervical spondylosis, patients who are very anxious, of an anxious disposition, and wouldn't possibly be compliant in cases where we try to do it manually. And despite having the VNG, there is a lot of cases that can't be diagnosed because we can't position the patient in perfectly the 30-degree extension or 45-degree extension or rotation and 90-degree rotation. Or even when you see the chair, if I'm going back, there is this top lever there. So it has 45-degree angles perfectly placed in it. So once you release the lever, the chair can rotate on its own axis, and the speed can also be controlled as per one's wish. So that is the main purpose of the chair, that everything related to vertigo can be done despite it being a patient who is not very ambulatory. Even if it's a patient with arthritis or something, they can still undergo this therapy. And in our experience, we have actually the oldest patient that we have treated is a 92-year-old female patient who was quite frail, but the main complaint she had was was vertigo, positional vertigo. So we actually treated that patient on this chair, and it was it was a really nice experience to have.
Basically, in a conventional method of diagnosis or a therapeutic maneuver, for example, commonest maneuver, Dix-Holpig, all the patients you need to rotate the head 45-degree. Then you bring him for a diagnosis, you bring him down with a head extension, and after a minute you bring back. Now, during whole of this procedure, the rotation is to be maintained, extension is to be maintained, and simultaneously, because of vertigo, so many times it happens that patient himself changes the position. Sometimes because of a cervical issues, cervical spondylosis, rotation of 45 degrees is not possible. So these were the issues where diagnosis was not perfect. Now in the chair, the provision is you don't need to rotate the neck. You can just rotate the whole chair at a 45-degree, and which is exactly managed by the arrangement in the chair. So exact 45-degree rotation will be there. The body is with the harnesses, body is fixed with the chair. So while you bring down, in a diagnostic or a therapeutic maneuver, the most important thing is a speed, rapidity of the movement, particularly in therapeutic maneuvers, so that because of a reverse flow of endolymph, particle moves in a towards non-ampullary region. So speed, rapidity is very important. Then maintaining that position and angle is also possible. Sometimes an additional acceleration force is required for a shifting of the particle. that provision is also there on the chair. And because of a 3-axis rotation, you name the maneuver, and you can do it. Whatever maneuvers are there in the literature, all the maneuvers are possible to do with at 100% perfection. Vishnu, can I share my screen? I can show one small video.
Yes, sir. You can share your screen, sir. You have access.
I'm lost.
In the meantime, if I would like to put out some points that were not mentioned in the presentation about the case at hand and how it was clearly a multi-canal BPPV instead of a central one. First of all, the very resolution of the disease with the maneuvers, it itself is an indicator of how this was a positional multi-canal positional vertigo of peripheral origin. But that was after we'd already made the diagnosis and already done the treatment. So before that, there were certain things that proved that it was a peripheral lesion. For example, the conformity of the nystagmus along with the orientation of the BPPV subtype. So for instance, if in left Dix Hallpike there had been left downbeating nystagmus, then it would not have been a proper diagnosis. But we had right downbeating nystagmus, so it was indicative of right anterior canal involvement. Of course, we went for the deep supine hanging test. We did not have the video to show for it, but it did show vertical nystagmus in that case. And along with that, there was a little bit of a latent period, and the nystagmus was of a crescendo decrescendo type, which showed that it was fatigable even if the duration was of a longer period. And due to the horizontal component, there was VHIT positive in both directions. The natural course of the nystagmus was very indicative of BPPV. So this was something that had been a very confounding factor in this particular case for so many neurologists and a lot of ENT surgeons. But thanks to the chair, we had been able to diagnose it properly.
Can I ask one question? Hello?
Yes.
How do you explain this bilateral head impulse test positive?
So in involvement of horizontal canal, usually they work as a pair. And as we know, the LARP plane and the RALP plane, and then we have the horizontal canal, which is a pair. So since there is involvement of either one of the canals, there is video head impulse test will be positive for both in certain cases when it is of a chronic nature, particularly because the patient has been suffering from this vertigo for a longer time. There has been certain compensatory mechanisms also taking place. Both the sides of horizontal canal work as a pair.
Thank you.
And since the left horizontal canal was involved and the right anterior canal was involved, so there was involvement of both sides of the vestibule, labyrinthine systems.
Using this chair, you can do all therapeutic maneuvers also. Simon.
All diagnostic and all therapeutic maneuvers can be done on this chair. So we even the Bangalore maneuver, which is a very recent one, even the bow and yaw maneuver with the mastered vibrator, even vibrations can be given on this chair. And deep Epleys or cement plus maneuver can also be done. So all of those attachments have also been given on this chair. So absolutely every maneuver that is in the book can and has been performed on this chair.
Okay, thank you.
All right.
Can you see this chair?
Yeah.
Do you hear the sound or not?
No.
Could you give a commentary then, Vinod? Could you give a commentary?
For example, cement plus manure. Here, additional vibrations you need, an overextension you want to give in a cement manure. So vibration plus additional extension provision is also there. For a supine test or for a horizontal canal, head flexion is constantly maintained.
What vibration is, what method do you use for vibration?
We showed a tube spring on an end of the chair, and by pressing on it, the vibrations can be given in a sequential manner.
Okay. And you have any specific frequency? Is it low or high?
Sorry, tell me.
No, is it a
Because
low frequency or high frequency? Do you have any
no, it's a
specific?
low frequency and continuous 12 for example, these vibrations we give when additional acceleration force is required, particularly in cases of copulolithiasis. So every step we give a 12 vibrations, and so it's a low frequency vibrations, and it helps in dislodging the particle from the which are entangled in the copula, and so it becomes very easy. So this is how I think. If you are not hearing the sound of this video, is of no meaning, but I don't know why. So practically, I can say you name the maneuver in the literature, and it is possible because of the 3-axis rotations everywhere, and we can fix the body, we can fix the head. Flexion can be maintained during all rotations or all positions. Wherever required, extension is also can be maintained, and performing diagnostic or therapeutic maneuver with absolute perfection is possible.
Excellent. So, are there any questions from the audience regarding the use of the chair? Hello.
Definitely, it's a great innovation because always when we do the when we do the maneuver, the speed and all these things that we have to maintain constantly, that is often not difficult because of some resistance and the phobia of the patient. So that this must be a very good, as far as the accuracy of the maneuver is concerned, this will be definitely better than what we do. It's a very good innovation.
Practically since last 8 years, I'm using it, and gradually we made a lot of changes in it, and ultimately we reached to the stage where we are able to do all the maneuvers with perfections. And now I'm confident that all diagnostic and therapeutic maneuver, for example, for a short-term cases, bow and yaw maneuver, so that is also possible. I think next time when time comes, I'm going to demonstrate all the maneuvers with perfection.
Is there any more questions from the audience? I think it's a good time. Otherwise, we would go into summing up mode. But I think I must congratulate Vinod for your
Thank you very much.
innovation. I must congratulate your daughter for her clarity of expression and her depth of her understanding. I think I was very impressed. I must apologize to everybody for my patchy reception, but these are factors out of my control. But Vinod, I am really happy, and I look forward to a lot of publications coming out from this effort of yours, and we'd be happy to work with you to bring that out. I was impressed by the fact that your daughter has a degree in medical research also, which I thought is something worthwhile accomplishing. So, all in all, I thought, you and your daughter have really done a good show. And on behalf of all of us, we like to thank you for your participation. Thank you very much.
Thank you very much to all participants, and special thanks to Dr. Ravi. Thank you. Thank you very much.